you are going to do today is first we're going to do an hour, just kind of high-level overview of dialectical behavior therapy, how it is structured based on the research right now. I'll talk a little bit about adaptations as we go through, but basically this is an overview of DBT as it's written. I'll start with a little teeny bit of mindfulness and debate about whether or not to put this on today's training. And in DBT, consultation team begins with mindfulness and skills training begins with mindfulness, and it was just very hard for us to let go of the idea of starting with mindfulness. So there's to be said about mindfulness, and the mindfulness skills are the backbone skills of DBT, and they really are about having clients get to a place where they're involved in their lives, kind of completely in lives in a moment, not attached to past suffering or worrying about the future, but about experiencing every moment as it comes and knowing their own experiences. So knowing their own emotions and thoughts. And what we do in DBT is practicing different ways to do mindfulness. So different skill mindfulness that we have in the skill training group, we have different practices. So about posture and how we're going to do this, but what I would like for you to do just for the sake of expedience today is sit straight in your chair with your feet on the ground. Keep your eyes open when we do this. Take your hands and put them in your lap in a position. So don't close your fist or close your hands. Just rest them comfortably in your lap. And then have a posture that's not slumping, that's not totally erect, one that's comfortable. If we're taking a 20-minute mindfulness, you could hold for 20 minutes. So we're going to do a minute or two. And what we're going to do is take 5 breaths. You don't change your breath when you do it. This is about noticing your breathing. So all you do is to breathe in, and as you breathe in, count 1, and you're breathing out, count 2. As you're breathing in, count 3, and count to 10 so that you have done 10 breaths. If you start again, although you have a whole lot of time to start over, judgmental of yourself, judgments go back. So you're just noticing your breath as it comes in and goes out and counting 1, 2, 3, 4. So I have this bell here, kind of sweet if I hold it up. 3 to start us and 1 to finish it. You'll see me leaning over. That's because I have a microphone that's attached to my head, and I realized earlier that you can't hear it unless I hold it closer. Okay, so we're just going to start. I'm going to talk briefly about how DBT came to be, and then just tell you a little bit about the structure, the framework, and the parts of dialectical behavior therapy. So this first slide is really about the research studies that have been done in DBT. There are actually 10 now studies that have been done. One hasn't quite been published yet. Randomized trials on DBT. The first one was in 1991, and that was the University of Washington. And it was PT versus treatment as usual. So what people were already getting in the community, kind of standard mental health treatment. It found that suicide attempts, inpatient hospitalization, emergency room visits, behaviors, all down in a year of treatment. So this one and most of the other ones were for the standard year of treatment. Then in 2001, replicated that study, but on the 6-month treatment in the VA in Durham, North Carolina, which was important because it was the first time somebody had done a study of the University of Washington and showed that basically other people other than Marsha Linehan could do the treatment. Safer have done some studies on DBT with eating disorders, with binge eating disorder and with bulimia, and so studies by them that show that it's effective, especially with binge eating, in bringing down the disorder. These also have some trials with substance abuse, like opiate dependent, with borderline personality disorder who were suicidal. So they were a group. And then Tom Lynch did DBT with the elderly depressed. He's now doing a study that is DBT with over-controlled people, thinking that borderline personality disorder, they're people kind of under-control their emotions. The emotions are big and control, and their behaviors are out of control. There's a group of personality disorders that are the exact opposite, that over-control everything. The other thing is with adolescents, there are a couple of studies going on now, kind of adolescent transition stage that has just finished in New Zealand. And a larger scale study in Norway on DBT with suicide adolescents. And they're just kicking off at the University of Washington and UCLA that is DBT with adolescents. It's a 6-month program as opposed to a long program. So what is DBT? Well, you kind of have to understand the history of DBT. So DBT was being developed in the early 80s, and who developed the treatment didn't want to work with people with borderline personality disorder. It's not that she didn't want to work with them, really. It was that she didn't know who they were. And she was not a person who focused on diagnosis. She was a person who wanted to treat suicidal behaviors. And she started trying to treat suicidal behaviors. She had this whole group of people that it didn't work with. And part of the problem was because they had so many behaviors. They would be drinking and drugging and binging and praying and suicidal and self-harming. Every time she tried to treat one thing with a treatment that she knew worked, because something else would pop up. It didn't really have a structure that allowed her to pick a behavior, change it on another behavior, and kind of know how to prioritize the session. In treatments over time, there was basically the acceptance-based treatments. Those were the centered therapies. You know, they use very low dropouts. People stay in those treatments for a long time. But the research hasn't shown that you get a lot of behavioral change. So the people stay around, which is really great. They don't really change their behavior. Then we have the cognitive behavioral therapies that are really change-oriented. They push people to change their behavior, and they teach them new stuff. And they're really, about you don't have the same behaviors that have been making you miserable, except that, especially in those early 80s, there's no emphasis on relationship and on acceptance. And with the out-of-control, really sensitive people, they drop out of therapy. And if you look at the data on personality disorder, especially, the drop rate was usually like 70 or 80%. So people weren't keeping people with BPD in treatment. We're trying to bring these two ideas together, the acceptance, like the client is, and acknowledging her current distress and reasons for it, and at the same time teaching her how to change behavior. And it really helps because people aren't great at problem solving. They're that's trying to help them solve their problems, they feel invalidated by you. They're saying it's all their fault. And we have some of that in DBT. If I'm always saying to the client, what are you going to do about your mom? How are you going to change your mom? Then in this case, I'm telling her that the onus of that is on her, of that change. And it really dysregulates these very sensitive people. So the bringing these things together with what we call dialectic. Dialectic balances out acceptance, so the client-centered therapies, and change the more behavioral therapies. And it doesn't have 50% and 50%. There are times when you're really strong on change. You know, you're really pushing. The client is working, got something to figure out. And sometimes when you back off and you're more about acceptance, and it says, how do you get that balance? One, it's a way of getting balance. So the way to clients is, if you're in a place that's extreme, miserable. And we usually use are, if you're too cold, then you're miserable. I'm always miserable if I'm cold. Hot, most people are miserable. I love people because I love hot. If too much to do, you're miserable. Many of us in the mental health field know exactly what that feels like. If you do, though, you're miserable too. Diagnostic says your life into a balanced place. Who have too much to do, we are here to balance. So what we're saying to our clients is keep balance in there too, so that your thoughts and your emotions and the behaviors that accompany them will be more what we call middle path. The other dialectic is it's synthesizing two positions. So what happens with people sometimes in therapy is they get polarized, or in an inpatient unit, or in a partial hospitalization where you're the saying, do this, do this, do this. The client is saying, I'm not, and here's why. And people having a tug of war, you know, and everybody is kind of attached to their position. And Diagnostic says, you know, there's probably truth in both positions. You know, there's the wisdom that the clinical team has and they want the client to do. There's the client's own ability and autonomy to say that doesn't work for me. And how do you bring those two to a new place? And when you do, that becomes another set of opposites. So part of dialectics is synthesizing opposing positions. And this part is looking for what we're leaving out. You know, the reality is going on the direction and we have our perception. What we see, we have to think to be truth in a situation and believe that stuff all the time because we're heading down this path. I do a lot when I'm teaching where, you know, I think I know where I'm going and I head off in one direction and I realize later that I left out like 15 things I wanted to say or would have been effective to say. And DBT says is let's ask ourselves constantly, what are we thinking out here? You know, what's seeing? DBT therapists all the time, they talk like this, like what do I do? What am I not seeing? What am I thinking out? We're acknowledging that we always see the whole and other people can help us with. And so we do what we call dialectical assessment, which is looking for the piece that we're leaving out. So role in the treatment. Well, that's what we're going to talk about for the next period of time. For how is DBT effective? So we talked about the research. So we know some diagnostic populations. We know borderline personality disorder, treatment-resistant depression. We're now knowing more and more about different eating disorder and about adolescents with emotional control problems and behavioral control problems. But what if a unit or system and take people's diagnosis, you know, an inpatient unit, and you have a whole group of people that come to you, for whom DBT might help? Well, 5 basic ways of looking at it. These are 5 problems that we can treat in DBT. If you have them purely, they are reconfiguration diagnostic criteria in the DSM-4 for borderline personality disorder. So all those 9 little pieces that make up BPD in the DSM are in these 5 areas. But Marcia very wisely, when she started writing DBT, looked treatable. You know, they things like frantic efforts to avoid abandonment, kind of in disarray. And I can see if someone gave that diagnosis and I looked that up in the book or Googled it, I would feel very hopeless when I saw it. And so these have been reformulated into 5 areas that are treatable. These are things that we actually target in DBT. And when we target these areas, bring that diagnosis down. So emotion dysregulation. And this is a primary problem in the people we treat in DBT. It is emotionally very sensitive, and they have trouble regulating emotion. So usually kind of out of control, anger, and that's on the diagnostic criteria, but often I see sadness and shame as being more problematic than anger. Anger is kind of the emotion that they experience sadness, shame. But also guilt, fear, anxiety, and no ability to really control that emotion. Often they don't know what they're feeling until later, what their emotions are, and when they come up, they're just kind of overwhelmed by them, and then they can't do anything, and so they just kind of go with them and engage in whatever the behavior tells them to do, which can sometimes have catastrophic consequences. I think as you see people get older, they often get punished for having emotional displays. And populations, when you get people who are middle-aged, where they actually have the opposite extreme, they like emotional over-control. So will say to you, I don't do that. I don't anger. I have those emotions. And you want this periods where it all kinds of bubbles up and kind of out of them. And, you know, a lot of times what they're having is kind of a suppression effect, where they suppress emotion, and then it kind of pulls up on them in the moment. That is the first, emotion dysregulation. The second, dysregulation. This is the reason that many people with BPD and other behavioral dysregulations come into treatment, because they get suicidal. They get harming, they cut, they burn, they pull their hair out, they binge, they purge, drink, drug, gamble, shoplift. They have what other people call impulsive behaviors or too many behaviors, like they overspend. And so we're often assessing for this. It's clear, DBT does not require that a person has suicidal self-harm behavior, and DBT does not either. So people sometimes will come into treatment with us who are not actively suicidal, they're not actively cutting, and that's okay, because often they have problems in all these other areas. In regulation, it's about regulating relationships. You know, it's a skill to have relationships, and you can see that if you were a person who had out-of-control emotions, it would be really hard to have out-of-control emotions and in-control relationships together. If your emotions get out of control, you end relationships prematurely or force relationships that are not wise relationships. So our people who come into treatment often have a really hard time with relationships. They think that they're going to end, that they behave in ways that actually end the behavior. So this is where behavioral dysregulation kind of meets in its personal dysregulation. They require a lot of reassurance sometimes. They're relationship phobic, so they just say, I'm not going to have any relationship except they're mutual, because they don't. Ask for what they want, get what they need in relationships. The fourth, cognitive dysregulation. So in a lot of people, this is attentional control. People have problems with ADHD or just basically being able to concentrate, even if it's for diagnosis. So we're paying attention with mindfulness, basically, and I will get to that in a little bit, but They also can appear to be a little paranoid, and it's not the diagnostic paranoia, but it's often cued up with what's happening in the environment, stressors that are happening in their lives, or they're not sleeping. Something's going on that kind of sets them up for paranoia. I had a client this morning who's got a lot of work stress, and he has one of his types of bushes in his yard is dying. He said, look out there and they're all brown. Said, oh, well, maybe someone's poisoning my bushes. He said, then my wise mind kicks in, which is kind of what is wise. And he said, and I realize that's not true, but for a moment I absolutely believe it. And really related to the stress in his life. And you can see this can happen, where people can't really talk themselves out of it as quickly as he can, where people actually get a little psychotic in certain environmental contexts. And this association and cognitive dysregulation, many of our people, depending on the research you read, but they dissociate. And so we do a really good dissociation assessment to see if they're losing time or if they're kind of have to use their language to see what's going on. Finally, really one of the more complex problems that our people have is self-dysregulation. This is not a self-esteem problem. It is a not knowing who you are problem. I often tell clients when they say, it's that I have poor self-esteem, that actually that would be that they are, and they don't know what their values are. They don't know what they like or dislike. And you can see them in a room full of people when decisions are being made, that they're kind of scanning the environment and looking for what other people are doing. And then they say, yeah, I'm going to do that, which is problematic, especially when they're young. They kind of dive in with crowds that can do things that are not helpful and don't even know that their values are saying not to do it necessarily. So people we look for DBT, like I said, you don't have to have all of these, but you want to have some severe pattern of these behaviors. And if they have borderline personality disorder as a diagnosis, you will see most of these. So to come into DBT, well, big agreement is that they have to stop suicide and self-harm behavior. To do that. Sometimes with the client, you have to agree to stop, and they say, okay, fine. Sometimes if they agree to work on suicidal behaviors. Your goal is to bring suicidal behavior down, to get it to stop. If they say, no, suicide is a lifestyle for me, cutting is a lifestyle for me, or I can't make that agreement, you don't move on with the treatment until you get that agreement. You can put some work into that. That is a necessary agreement to enter into DBT. Agree to attend to the relationship with their therapist. This is a pretty intense therapy. Although we don't meet every day, there's work that can be done. And to address the dropout issue for these people, one of the things that we ask is for them to agree to deal with relationship problems with us. Come to session, and they have to agree to whatever it is the system might agree to. So research protocols, payments, pediatric care, whatever it is that the system asks for. In return, DBT therapists agree to do DBT, which is a lot harder to do. What we say is, I will do DBT, and I'll get consultation, and I'll attend a team that will help keep my feet to the flame here and make sure I'm doing DBT. I'll get supervision when I need it, and of course adhere to all the legal, ethical guidelines that are around, and to practice within our scope of practice, which are psychotherapy agreements. 4 stages. You read the research. It's stage 1 DBT. From the system, people in treatment is they're in stage 1. And some people, if you have a short-term unit or unit, 6 months or less, they only have the people when they're in stage 1. Stage 2, there is a study being done right now, a really great study that we're looking forward to. Stage 2 DBT, and then stage 3 and stage 4, I'll talk about in a second. So what is stage 1? When a client's behaviors are out of control. All it is. They have to have multiple out of control problems in multiple areas. So when you back on that list, they'll have problems in a lot of those areas. And we're trying to get to happen there is we're just trying to get their behavior under control. It's dealing with the other problems in someone's life, getting arrested, or hospitalized, dropping out. So on those behaviors first. And in standard DBT, that's usually around a year of treatment. Sometimes people finish that and they're finished with us. But a lot of times you get their behavior under control and basically they're still miserable. They're staying because they aren't experiencing emotion, or they have trauma issues from the past or things that they have avoided. So DBT is like a prolonged exposure treatment. Help people experience emotions and situations that they may be avoiding. And a client who's like, I've been in therapy for 25 years dealing with my childhood trauma. I don't need it anymore. So you don't have to do it. But for people, when they're into therapy, part of what brings them into therapy is some kind of trauma that they had when they were. That is an important piece of the treatment for them. We do this in stage 2, when behavior is under control. And the way I explain this to my clients is that, when we do trauma work, trauma is grueling. It's painful. It's kind of its own crisis. Your level of functioning is really great. You've got meaningful relationships and you can regulate emotions and behaviors pretty well. It's still its own kind of crisis. If you have other crises going on in your life already, then new trauma work on top of that really can set you up for what one client calls a crash. It can be, in many cases, more suicide attempts, higher levels of self-harm. So is work or exposure work or work on anything that's about experiencing those emotions. So basically now you have behavior down and emotion experience and misery coming down. So a client who just has kind of ordinary, I call it pit-stop therapy. They come in for marriage therapy or vocational therapy, or they have, some depression firing up, and so they might come into therapy for that. Or they have a panic attack, and that's all they have left. So you kind of have a single treatment for which a problem for which there's a treatment. I call that stage 3. Some people do that in DBT. Some people finish at that point. And stage 4 is highly theoretical. I would love to say that we've written this, but we've tried to write it for a million years, and we just haven't gotten it done yet. But it is basically, they get everything under control, lives are moving along, but they just need a greater depth of experience in their lives. And stage 4 is whatever that might be. It might go into psychoanalysis, it might be, going on spirit retreats or finding a spiritual path, but I can point people in that direction. Usually when I'm pointing someone in that direction, they're finished with me, and I'm like, here's the next step, and send them on their way. So I said the one that most of us see, and if you're an acute unit, then this will definitely be more of what you see. And it has specific behavior targets. And if you remember at the beginning, I said that one of the things that Marcia was that there were so many problems that were percolating around. It's difficult to choose which problem to work on and to know in a session when a client came in just with all these things going on, how to prioritize it. The structural pieces of DBT, that we go ahead and prioritize that. We use a treatment hierarchy. Our brain is at all time, and when the client comes in and a lot of problems in a week, this is how we sort behaviors into what we're going to do in a session and what we do overall in the treatment program. It's not what skills trainers do. Skills have a whole different set of targets. Skill coaches have a different set of targets because most people don't actually work on the life-threatening behavior. They coach the client until they can get to the person who works on the life-threatening behavior. So the goal of DBT to get along with it. It's suicidal behavior. Suicidal behavior is fundamentally my life does not work with it. So people who have meaningful activity and relationship, things that make them feel valuable, and then say, and I want to die, and I want to kill myself. The people who don't have those things, who want to kill themselves. So one thing we ask your clients to do is to come up with a life worth living goal. And the therapy goal, as you think about kind of therapy goals, this is, what is it that makes your life better, that you think would make your life better? A lot of times for adults and for adolescents, coming up with some kind of career or vocational goal. But sometimes it's a relationship goal. It starts out just, I want to be happy, and then you've got to work on what is happy and what makes you happy. Sometimes you start on one goal, and then the client realizes that wasn't their goal at all, and they're going to switch goals, which is their thing. But they can be anything. I had a client one time, I've actually had several clients, who was to get married. That's what she figured she would not be suicidal if she got married. I have right now, her whole goal is to have friends. She has having friends, so I can understand that would be a goal. She can't really make friends or keep friends. But what we're working on, now we have to get some problems in this. Some problems. There are some things that are keeping her from having friends. She's a call constantly if she's their best friend. Gets distressed if the person talks to anybody else. These are all things that we put on that list of problems that are keeping them from the life worth living. The first living goal is to have friends. You take and then you map these targets on it, which is this. The number one thing, the number one priority in any session is increasing life-threatening behaviors. So homicide in some cases or assaultive behaviors. Work on bringing those down. So if a client comes into session, they've engaged in any of those behaviors or if their ideation is spiking, baseline of 4 out of 0 to 5 scale, like they're pretty subtle all the time, but it spikes up to a 5 one day, or my clients on a 0 to 5 scale will get a 10, which I figure is pretty catastrophic since my scale stopped at 5. Then you're sure that the priority of the session goes to that behavior. It's hard to get friends if you're deaf. Doggone near impossible. It has to be to keep you alive. And, I told the friend girl, it's not, people don't want to be friends with suicidal people. You hear that, by the way. She thought that people would want to be friends with her more if she was suicidal because they feel sorry for her. And they feel sorry for her, they wouldn't be hanging out. And most of us don't have this criteria for friends. So I agreed to work on not being friends with suicidal. That's what we call therapy interfering behavior. We want to decrease therapy interfering behaviors. Therapy interfering behaviors are anything that affects our client or the therapist's motivation to be in therapy. So clients coming late, not doing their homework, marginally disrupted on a unit, in all of that can be therapy interfering. Coming late, taking calls, leaving for code, not kind of daydreaming while the client's talking. Those are therapy interfering behaviors on the part of the therapist. And in one of those, it causes the therapy to collapse. So we say, the only thing that's more important than the relationship is my life. I ask them, is there anything that we need to talk about with the relationship? I'll look and, observe myself and say, nope, nothing here. How about you? But I try to get them so that they can talk about what their experience of the therapeutic relationship is. If they drop out of therapy, I'm not going to be helping. Quality of life interfering. So if you have a self-harm behavior that week, address it. Don't have therapy interfering behavior, or address it. Then you get into quality of life interfering behavior. And I write a list of quality of life interfering behaviors for all my clients because, by definition, they have multiple quality of life interfering behaviors. Put them in a little hierarchy too, because they can have 5, 6, 8, 10 of these. So, substance abuse, disorder behavior, gambling, shoplifting, having problems with work, having problems in a relationship, all those would go over as well. Come in and we're doing this little agenda with the targets. We just say, what do you want to be working on? All of the behaviors should decrease. Behaviors we want to go down. So you can't make a behavior go down if you don't put something new in its place. It just won't come into a vacuum. So people learn new behaviors. And 4 sets of skills that are our skills training in DBT. So the first mindfulness skills, we've talked a little bit about mindfulness skills, but the skills of how to know your own experience, engage in it fully, beat up on yourself, live your own wisdom. Tolerance skills, which are how you get through the moment. Like, stuff happens in life, and we're always telling our clients that being skillful does not mean that you're never going to have distress. Things aren't going to happen. It's a part of life. But often what happens with our clients is something happens. They get from their bank that someone may be stealing their identity, and they can't deal with that because it's the weekend. That emotion goes up, and they can't tolerate it, and so then they go out and get drunk, and then they, spend what they didn't have, and then they're guilty about spending that money, so then they end up with a suicide attempt or self-harming. And we're saying, here's what you do when life interferes to keep things from getting worse. So you don't engage in out-of-control behaviors. How do you focus your attention? How do you do other things to keep yourself from engaging in impulsive behaviors? How do you slow your response down? So if you decide to go out with your friends, you're not going out with your friends and getting drunk. In personal skills, pretty self-explanatory, but it's really how you ask somebody for something, say no, get your opinion taken seriously, and simultaneously keep that relationship balanced out, and simultaneously about yourself. What I like about our people is they often get people to do what they want. Suicidal behaviors, or they'll get very dysregulated and distraught. They'll plead and give them something, but they'll like them after this. So the relationship, but they got what they wanted. Or they might get what they want, and still like them, but because they tried to get it, and then they out themselves. So interpersonal effectiveness is how you juggle all 3 of those things at once, so that it kind of comes out on the side of keeping relationships and keeping yourself. So emotional regulation. These are complicated skills, but very necessary. And how do you know an emotion? A lot of our clients say sad, mad, glad, and bad. And they don't really even know what those emotions are. So being able to look inside yourself and say, okay, my heart's beating fast, my blood is rushing, my stomach is clenched up, I have an urge to, go to my bedroom and shut the door and avoid all of this. Oh, this is fear. I'm fear. research shows that the minute you can name an emotion, it automatically starts regulating. It starts more manageable. So what we do in emotion regulation is teach people how much emotion they're having. But know it, then decide what you want to do with it. Do you want to sit around and use it for what its function is? Do you want to change it? Do you increase positive emotions in your life so that you balance out emotions, so that you freeze the more positive times, so that you can use those when you're distressed? Experience a negative emotion when it's to experience it. You know, bad happens in your life. If someone who you love dies, then experiencing sadness and grief is what you got to do to get to the other side of it. And sometimes people don't do that. It's because they're so afraid of emotion. So how do you let yourself have that emotion? That's really difficult. All things that we teach in our skills training group, these are new behaviors to replace their old behaviors. So this is what comprehensive DBT looks like. A lot of people say, well, we're just doing skills training. I wouldn't tell anyone not to do skills training, because I think as usual skills need to be able to have names to put on skills when I'm distressed. Skills training group alone is not DBT. What you have to be DBT is you have to meet 5 functions. These are functions of DBT. I will tell you what some of the ways are that people meet those functions. So this is to enhance capabilities. A lot of times when a person is engaging in out-of-control behavior, so let's say they're cutting, other people get really judgmental and say, she just wants to do that. She doesn't feel better. She's just getting attention for that. It is that what she knows how to do in that moment when she hurts herself is cut herself. That's all she knows, right? She has to say no. These are other things to do. Those 4 areas I just talked about, those are skills. They enhance the capabilities. To enhance capabilities might be a psychoeducational group where you teach people about how families function, or medications that helps people be able to use skills that they're learning. The function is improving motivation. So of us, when we're trying to change your behavior, is we have behavior, we know. Like, listen, you're trying to get yourself to exercise. Well, you know how to use the Bowflex, aortic tract. You may actually have it. It may be in your basement. And you're on, and you know how to put your tennis shoes on. You know how to stand on that treadmill, and you actually know how to walk, right? So you have all the capabilities. What you don't have is the motivation. So you spend all weekend thinking about and telling people how you'll start getting on the Nordic track on Monday morning, and Monday morning comes. Track. That's having a motivational problem. And what we have to do in DBT is figure out what that is. Sometimes if the emotions interfere, not on the Nordic track because you have anxiety about not getting in shape. It could be that you have thoughts that interfere. If it work, I'll never keep it up. Why exercise today? Because I won't tomorrow. I've had these failures for a long time. That things are reinforcing in bed behavior as opposed to getting on the Nordic track behavior. So you're tired, and it just feels better to do this. So when we have some judgment about motivation, it is that you've got to have a mechanism to look at what is interfering with the person actually engaging in the behaviors that they have. Usually it's done with individual therapy. On residential units and inpatient units and partial programs, a lot of times that's interventions. That's where people are constantly talking to the client, the client. Now, what caused you to do that? Well, what interfered with your using this skill? The people surrounding them are with improving motivation. Association is really important. All DBT programs have to have some way of making sure that what the client is learning, what it knows how to do, gets from one context to the other. Human behavior does not generalize. So you can learn something in one context and not be able to do it in another. A prime example of that, if you've ever tried to give up smoking cigarettes or talking, maybe do it at home. You saying you slam a candy bar, right? Someone said to you, you eat it, or you looked in a drawer and you found the candy bar that you had hidden, or you just were having a really bad day. What works at home doesn't necessarily work at work. Some way of getting the no chocolate at home behavior to get to the opposite. And is we put people in place for that say, oh no, remember, you said you weren't going to eat chocolate. This is what I want you to do. Oh, that breaks my heart to say that, but that's what I'd say. Throw it away. Give it to somebody else. Association has to happen, and it happens in different ways. One way is to get people to do homework from skills groups. So actually say, you got these skills, you learned them for no chocolate behavior. Let's practice how you engage in no chocolate behavior. So go to work, and I want you to say no one time to chocolate. Here are the skills for saying no to chocolate. Come back next week and tell us how saying no to chocolate works. It's coaches that are in the middle use, where staff can say, they just offer you a candy bar. Let me tell you how to say no to that candy bar. Here's what you to say. Say it. Fabulous. Wonderful. In DBT, we use telephone consultation. So they call and say, I've got the candy bar in my hand. You do. And we tell them the skills to use to get rid of the candy bar. Or do they know to the candy bar? Candy, what can I say? That's an easy example, but it seems to work. Making sure that what we're doing in our area and the behavioral change as best it can. And then, in what's possible, helping the client to structure their environment. It supports what we're doing, because it's very easy. I'm sure you guys have all seen this, where you have a person, they're in treatment, and have them changing behavior, and then they go home and they try to do what they were doing with you, and somebody at home either reacts negatively to it, or they do what they've always done, and it punishes that behavior inadvertently. I don't have judgments about this happening. It just happens. That's how human beings are. So you got to have a way of making sure that that's not going to happen as best you can. So one way we do that is we bring in family members. We do friends and family groups or caregiver groups, or they might come to skills training groups. So they learn what we're doing, how we're doing it. They learn to regulate emotion better, and they learn ways to respond to your client or yourself in ways that are more effective. Make sure that our structure supports what we're doing. It's really easy to get away from this. The day I worked with my original DBT programs that I really wanted was to have time on Fridays to do paperwork. So they told their clients that they were not available to coach them on Friday afternoons ever. But they call the emergency line. It's a mental health center. So what happens at Friday afternoon at 40 when a client calls an emergency line at a mental health center that closes at 5 o'clock and says, I'm suicidal? Say, go to your local emergency room. And people were getting admitted on Friday afternoon during that time. So we realized that that's when everybody was getting admitted. what we had to do was find another solution. So what we all did is we agreed to keep taking phone calls and answer the phone during that time. But we had to make some intervention because it was kind of reversing what we were trying to do through best of intentions by everybody. So the environment is a piece of DBT. You got to treat the people who are treating these out-of-control clients. So have some meeting that encourages and does for your therapist and your staff what for our clients. And we call that consultation. Only the DBT that's absolutely mandatory. Everybody who is doing DBT in clinical form has to go to a consultation team once a week. I got 6 hours on that right now, but I'm not going to. So basically, when a client comes into standard DBT, they go to group once a week, they go to individual once a week, they get telephone consultation as needed. We structure the environment by giving families and strike education and case management as needed, and then everybody goes to consultation. Everybody knows that DBT still is a kind of behavior therapy, which means that we do all the pieces and parts of standard DBT in DBT. A big piece of what we do is called the chain analysis. It's a moment-by-moment examination of the problem behavior that a client has with new skills put in. We call that solution analysis. So exposure and contingency management, and that's part of that overall structuring of the environment of your clinic, is that you look at what agencies are at play and how you might modify them. This CBT is valid. And I already talked about validation certainly at the beginning of this talk, but validation is the primary acceptance strategy in DBT. It is about saying to the client, your experiencing, thinking, feeling makes sense. I understand. There's truth in this. It's really hard to pull a little bit of truth. All of this kind of dysfunctional and emotional behavior going on. And you look for, of course she's experiencing that. Of course she feels like shutting down that emotion. That emotion has scared her when she's had that emotion in the past. It's had catastrophic consequences. So of course she's looking for a way to do that. It doesn't have to be cutting is valid. I don't say to anybody, and never has, well, I can understand why you cut. Totally effective way of changing. But you don't validate the invalid, but look for something that can validate. It serves a function and bring the client's emotion down. So you're kind of like a barometer where you're watching, and the client's emotions start going up, and you validate and bring them up. And then it's when they get down, you kind of change. And up again, and you validate, and you bring them down, and you back to change. And that's a little bit of the depth of DBT. Slide in, so people could get it. It's more philosophical than I really want to be in this moment, but it's about how dialectics is how you see the world. And we believe that we are connected to our clients and they're connected to us, and we impact and influence each other. And a big piece of that is then that we are beholden to the same behavioral principles that our clients are. They can engage in behaviors that reinforce and shape our behaviors, or vice versa, and all kind of moving along in this kind of connected way. We don't exist without everybody else in their family and everybody else on the unit. This all together, I feel like 5 minutes, I think. Putting this all together is the way you balance out this acceptance and the change. So making sure that your client is moving forward, but you are also validating and encouraging and soothing and acknowledging their experience in the moment. the treatment lines up between these ideas of acceptance and change and this primary dialectic of acceptance and change. And I'll show you another slide, and it shows that, so I will come back to that. I just want to ensure that everybody who sees this video knows the consultation team is of utmost importance. Parents get ineffective with clients if they don't have some mechanism to keep them from burning out, to keep rigid, and to make sure that they do the treatment. Even starting with just skill training, make skill training and consultation teams, because training can be a little dysregulating for the therapist. When we have 8 or 10 or 12 people in there who are highly dysregulated themselves, it can be difficult. Any DBT has to be in this consultation team. They agree that you'll come every week, that it will be a priority, that of course if you're on vacation or sick. You won't be filling out treatment plans or doing other things in the team, that you're discussing each other or issues out of the team, and an agreement that we will all be equally vulnerable. So hierarchy does not enter into the consultation team room. This is a very difficult thing to do if you're in a hierarchical environment. When you have supervisors on teams, sometimes you have non-clinical staff on team, provide evaluations for other people on the team. It's everybody leaves that piece out. And when you come to the team, everybody is equal. All right, so you've got the central dialectic. So this is the orchestra of DBT. And, you know, orchestras have all these different instruments. And so they have the woodwinds and the brasses and the strings and the percussion and the pianos. And they're playing their own little parts. And sometimes they're playing really different parts. And then they have the conductor who brings them all together and the percussion that kind of sets tone. And when it all comes together, it becomes music. It becomes beautiful music, hopefully. DBT is. We have acceptance, which is like one set of the orchestra, with management strategies and how we communicate this kind of warm, genuine involvement. And on the other side, we have the brass section, you know, that's change, that's about how to intervene with the client so that you teach them how to be their own interventionists and use irreverent communication, which is responding just a little unexpectedly. And then CBT principles. Then your consultation team, that's the question section that keeps everything kind of moving along at a pace. It sets the rhythm. It keeps everybody going together. And you have dialectics, which is the composer, who brings up this section and brings this section, speeds up, slows things down, says get louder, get softer. That pulls all of that together so that it becomes music. So watching this you do to figure out who's going to be on your consultations and who you're going to treat, what kind of program you have, and what are going to be the pieces and the parts of the program. Then to actually learn DBT. It's going to take some time, and I recommend getting an expert or a supervisor or a consultant, somebody who can make sure that you're actually doing what you think you're doing. It's easy to get active in DBT and take your whole program in a direction that you don't want to go. We're going to answer questions now. So we're going to turn back